मैंने मेरे इसमें डाल दी.
Okay. And we are going live.
Yes. Shall I start?
1 minute, ma'am. 1 minute. I'll introduce you first.
Let me share the screen. And you can read from this thing so that we can go. Yeah.
Good evening, everyone. This is Piyush from Corona Remedies. Welcomes you all once again to the series number 10 by Sunita Tandulwadkar, ma'am. Her personality does not need any kind of introduction, but yet again, I would love to introduce her with you all once again. Dr. Sunita Tandulwadkar, Head of Department Obstetric and Gynae and Chief IVF and Endoscopy Center, Ruby Hall Clinic, Pune. Advisory and consultant to Dr. D.Y. Patil IVF and Endoscopy Center, Pune. Founder and medical director, Solo Clinic IVF, a center for excellence in infertility, Pune. Founder and medical director, Solo Stem Cells, a stem cell research and application center, Pune. She has a lot of achievements. If I start mentioning one by one, it will take hours and hours to explain. But
let's go, Piyush.
Okay, thank you so much, ma'am.
First of all, I need to thank Corona. Corona is working really very hard, very sincerely. Dipesh Bhai, Vasu sir, all are helping so much in academics, in spreading the knowledge across the globe. Corona series is the one which is not limited to India. We have the viewers from all across the globe. And thanks to the persistent efforts of Team Corona and Piyush, you are doing an amazing job. And you get tortured by listening to my all talks.
No, I'm absolutely not. It's a delight to learn from the best.
And thank you. So namaste, vanakkam, sasriyakal, namaskara, chibai, and thank you once again for all of you for joining me today in this webinar where we are going to discuss about PCOS and insulin resistance. Friends, advances in science. These are my two favorite slides. Advances in science is always for the betterment of human being. And in science, what is important is to modify and change one's idea as the science advances. Sorry. Now, what has happened in PCOS is the PCOS, what we used to learn 3 to 4 decades ago during our residency, Steen-Leventhal syndrome, ovarian wedge resection, the treatment, all that has massively changed. We came to know that PCOS has its own racial, genetic, and so many other influencers and factors which affects our understanding of the subject, pathophysiology of the subject, various medicines and its studies, effects in the PCOS have kept on increasing. But there are certain areas where we still have a dilemma. Should every patient be investigated and treated for insulin resistance before fertility treatment? Today's my topic of discussion is, we discussed twice PCOS in previous webinars, but they were overview of a PCOS. There was ovulation induction in PCOS, but I felt this is the burning issue. Whether insulin resistance, am I supposed to investigate? And am I supposed to treat it before I start? We all know that PCOS is most common gynec endocrine disorder, widely considered as a top cause of infertility and globally affecting around 8 to 13% of the women in reproductive age group. So today I'm going to discuss on how frequent is the insulin resistance. If I'm supposed to investigate and if I'm supposed to treat, First of all, it should be logical that it should be common to investigate and to waste energy and money in it. Is it easy to test? If I know that it is, yes, very much common in PCOS, the insulin resistance, is it easy to test? And the test which I'm doing, are they reliable? Does it really affect the fertility? And if I treat it, will it improve the fertility? And if so, how to treat them? These are the 5 points on which my entire 30 minutes talk will go. PCOS, we all know, is characterized by hirsutism, hyperandrogenism, ovulatory dysfunction, menstrual disorder. To date, its pathogenesis is unclear. However, insulin resistance is considered as one of the primary pathological bases. And friends, how frequent it is, regardless of obesity. Don't think that the only obese patient will have an insulin resistance. Regardless of obesity, 50% of the PCOS patient have an insulin resistance, and that's why we have to give an importance to it. It is, well, in few studies, it is labeled that its prevalence can be as high as 80%. So 35% to 80%. Now, hyperinsulinemia, we all know that there will be increase in the pituitary LH secretion, which itself will cause hyperandrogenism from the ovaries and from the adrenal gland. And hyperandrogenism and hyperinsulinemia will go hand in hand. If you go on a PCOS and you put it in on a PubMed search, you will find thousands of publications. I have considered few which are important, like insulin resistance is inherent in women with PCOS, regardless, as I said, you obese or lean, and hyperinsulinemia ensures as a result. It has proven difficulty to quantify insulin resistance. So the incidence, yes. Quantification, very difficult due to its limitation of the methods to be used. I'm coming to it. Prevalence, again, maybe as high as 44 to 70%. And they have said that, yes, obesity and it can go on. Now, how to test the insulin? So first of all, I know hyperandrogenemia, hyperinsulinemia will go in hand. Patient of hyperandrogenism, that is acne, that is hirsutism, probably have very high chance of having a high insulin levels. But how do I test it? I also know that apart from obese, even the lean PCOS have huge insulin resistance, and they are difficult to treat. So the hyperinsulinemic euglycemic clamp technique, I'm just going to tell you about this technique because we don't use it. So just you should be knowing for its awareness. That is the really gold standard method for assessing the beta cell sensitivity in human, quantifying the amount of glucose metabolized by the body following a controlled hyperglycemic stimulus. So you give some glucose to the patient and then you measure this. However, it is not possible in the clinical setting. Since the glucose clamp is difficult to apply because of its chaotic procedure, we need to have the surrogate markers. And over the years, simple markers have been developed and used, and they include anthropometric and biological indices. Now, what are their advantages and what are the limitations of these anthropoetic markers also? I'll talk to you. This is in 2020 publication, which has come. In women with PCOS, BMI is an independent predictor of her insulin resistance. However, it is not routinely used as a surrogate marker. Just now I told you that basal metabolic index, BMI of the patient, even in a lean PCOS, you will have it. So it is not a surrogate marker. Indeed, since insulin resistance in PCOS is independent of the body fat, it could not accurately be predicted by BMI in lean PCOS. BMI correlates more closely in overweight and obese than in lean PCOS. So probably BMI may not be for all. A considerable correlation was taken into the waist circumference and insulin resistance. So a wide waist circumference, more than 80 centimeter, is shown to be associated with insulin resistance. But again, when we talk about waist circumference, we talk because of the fat. We talk only in obese because in lean PCOS it will not be. So it cannot be considered as a real biological marker in all the cases, the waist circumference. So several studies have proven that failed to show any association between waist circumference and insulin resistance in lean women. And it is safe to say that waist circumference could predict in overweight and obese, but not in lean PCOS. So what is lean PCOS we can think of? Waist circumference. Waist circumference is the best anthropometric marker known to date for the assessment of insulin resistance in PCOS. The novelty of the waist circumference is it is based on the bone and not on the fat. But the problem is no studies have said how much should be the waist circumference where you will label this as a PCOS and what is the cutoff value below which you will say she doesn't have it. Unfortunately, till today, there is no 100% cutoff value, and that's why waist circumference cannot be considered. Then I go for a biological or a clinical markers. Can I do fasting insulin as a simple office-based method? But the fasting insulin for assessing insulin resistance in women with the PCOS is limited by the lack of adequate laboratories and the cost of an insulin assay. It is not possible to do the serum insulin level by many labs. And that's why, and it is very expensive method. Now, how do they do it? The HOMA technique. Homeostasis model assessment is a method to quantify the insulin resistance from the basal fasting glucose level and insulin level. So what they do in HOMA is they do certain multiplication, and with this calculation, the laboratory only gives you. The principle here is that there is an interaction between the beta cell deficiency, insulin resistance, and fasting sugar levels. And with this graph, they will tell us whether there is an insulin resistance. A strong linear correlation between the HOMA insulin resistance has been found with the euglycemic hyperinsulinic clamp. It is proven to be a robust clinical or epidemiological tool. And then there have come the modification, little improvement, and there is a log HOMA insulin resistance. It is more clinically strongly recommended than the HOMA IR. So here, what they do is they say this is a better predictor. So they take a log of the HOMA value which has come. So this is again a lab calculation which comes through the software, and then they give us whether the patient is predictive or has insulin resistance or not. But all these tests becomes little expensive and may not be available. Then came the Quickie, the quantitative insulin sensitivity check index. Quickie is an index of insulin sensitivity that provides a consistent and precise index of insulin sensitivity. It is again calculated from the basal glucose and insulin correlation. That is, it is similar to HOMA, but Quickie is equal to 1 divided by log insulin in micro ml per ml plus log glucose milligram per decil. This formula implies that lower the Quickie value, the lower the insulin sensitivity will be, because it is 1 below this. Now, the thing is, again, this is a lab test, and the lab will give us the Quickie result. In women with PCOS, Quickie is among the most thoroughly evaluated surrogate indices for insulin sensitivity. Now, is insulin resistance the culprit? Before I go for this, so we understand that there are these markers which are little expensive, calculative, and dependent. So, do every infertility specialist do it in their practice? And do I do it in my practice? No, I'm not doing fasting insulin to find out the index and to find out. I go with my clinical son. Now, just 2 days ago, there was a PCOS conference, and I was moderating the panel where we had mixed panelists, the endocrinologist, we had the ART consultant from India, we had an ART consultant from Australia and from Indonesia. Why I'm talking about? Because we know the ethnicity affects. Most of them, they all said they don't check the insulin resistance in their day-to-day practice because it's quite complicated to do that. And instead, they start the patient with the treatment thinking that it will be an insulin resistance. So, friends, these are the tests. It has to be, the prevalence is very high. So it has to be acknowledged because it does affect the fertility. Now, how does it affect the fertility? First of all, insulin resistance, it causes ovulatory dysfunction because we know it will cause a high LH causing hyperandrogenic condition, and that is a unfavorable atmosphere in the ovary, and that will not give a healthy ovulation. But at the same time, there is an endometrial disorder also. There will be asynchrony in the endometrial growth, and that's why the receptivity window gets affected in the PCOS patient. Insulin resistance has long-term and detrimental effect on the metabolism of the patient. And this is very important, that we should not just tell the patient that you will have a fertility problem and I need to, but also you got the patient in front of you, sit and tell her in third, fourth, fifth, sixth decade of life, what are the problems, not only the metabolic syndrome, but other problem also, especially with the genital tract, especially with the endometrial hyperplasia, and especially with the CA endometrium, you should be talking to the patient. Now, this is very complex slide, but in 2 minutes, if I have to explain to you, this is the brain, this is the ovary, and this is the granulosa cells, and this is the theca cells. So what happens is, because of the high LH, there will be high androgen. And because this androgen comes in this, there will be again hyperandrogenic condition, and there will not be healthy oocyte. If you see on the right side, the lady, hyperinsulinemia will affect the liver. There will be a reduced sex hormone binding globulin. So there will be high testosterone, high androgen in the circulation, giving all the manifestations of hyperandrogenemia. It also has hyperinsulinemia will go and affect the ovary and will cause increased bioavailability of the androgen concentration there. And increased bioavailability of the androgen obviously will not allow the ovulation or a good ovulation and causing ovulatory dysfunction. A hyperinsulinemia always will go to the adrenal gland and will cause increased adrenal production. Again, because of the reduced sex hormone binding, there will be increased bioavailable. And these bioavailable will go into the theca cells. And from theca cells, testosterone again coming down and giving all the vicious cycle of hyperinsulinemia and hyperandrogenism. The excess insulin production can trigger the insulin receptor of pituitary to release the LH and to promote secretion of androgen by ovary as well as adrenal gland. Besides, it can inhibit the synthesis of sex hormone binding globulin from liver, allowing increased level of testosterone. And excess androgen secretion will inhibit the growth and development of the ovarian follicle, causing ovulatory dysfunction. Insulin can also enhance activity of insulin-like growth factor receptors in the ovary and it increases its level of free IGF, promoting again the production of intrathecal androgens. Insulin resistance as a characteristic of metabolic feature of PCOS affects the physiological function in uterine endometrium relating to the endometrial receptivity. And that is why the endometrial receptivity of patients with PCOS is worse than the normal woman. Excuse me. So it's not only the ovulatory dysfunction, but the endometrial receptivity also is affected. Insulin resistance can lead to reduction in the level of glucose transporter and the other glucose transporter proteins in the late stage of endometrial hyperplasia, leading to shortage of a glucose supply to the endometrial cells, thus the onset of endometrial development disorder. Moreover, the hyperandrogenism induced by the insulin resistance can inhibit the growth and activity of endometrial cells by interfering with the glucose metabolism, inhibiting decidual differentiation. So friends, remember, this is very, very important. Up till now, majority of the time, we used to give importance only for a ovulatory dysfunction, but try to understand the endometrial dysfunction also. So this is a very crowded site, but I explained you. Now, is there a relation between an AMH? So AMH is easy to test. If the patient's AMH is 7, I should say, okay, she will have insulin resistance. If her AMH is 4.2, she may not have insulin resistance. Thus, there is any correlation? Unfortunately, no. Serum AMH level in women with PCOS are not significantly different with the insulin resistance and without insulin resistance. So see, these are the several studies they have seen, and they have taken cutoff even of 2.5, and they found that there is no correlation. But positive correlation between BMI and insulin resistance, especially more than 25, that is obese PCOS, one of the inference of that study. So now, if I know that it is causing all, if I improve the insulin resistance, will I improve the fertility? So systemic review in 2021, 10 RCTs were included. Improvement of insulin sensitivity increases the pregnancy rate. Clinical pregnancy rate was increased in infertile PCOS patients when they had a significant improvement in insulin sensitivity after treatment, regardless of intervention. The benefits of improving the sensitivity appeared superior without severe obesity. Even without obesity also, it is better. The effect of improvement on pregnancy rate was independent on a change of BMI. And that is what I'm saying. Even in a lean PCOS, where there is no question about improvement of a BMI, just by the treatment of insulin resistance, you improve the sensitivity, you will improve the pregnancy rate. Non-surgical therapeutic strategies that promote this superior insulin sensitivity improvement may aid to increase their possibility of this. So don't try to go for a surgery. That is a bariatric surgery I'm talking about. So we need to improve it. And how do we then do that? So first of all, most important is lifestyle. I'm sorry, the slide of lifestyle is not there because I discussed in length about the lifestyle in my previous webinars. But remember, in lifestyle, apart from smoking and alcohol, low carb, high protein diet, and very heavy exercises. They have to work out on both the things, calorie deficit diet and excessive vigorous exercises. Both are equally important for these patients. And that's where the basic. So when patient comes to you in your cabin, obese PCOS, let's take obese, BMI is 30. And she says, I'm tired. Please start me the treatment. Friends, don't do that. Because with such a high BMI, And especially if she's showing you hirsutism and all, her sonography is showing you good PCOS pattern, you need to sit with the patient, counsel her. Now, how much BMI I should tell her? She is, for example, 92 kgs, at least 10% of the BMI. And the endocrinologist will say at least 5 to 7% of the BMI. Even if she leaves you, go next door, don't worry. She will not get a success. She will come back to you after 6 months with the failure of ovulation induction next door. So always remember, sit with her, talk to her, and ensure that she does at least 7 to 10% of reduction in her body mass. She has to go not only with the cardiac and other exercises, but she has to have the calorie deficit diet and the low in carb and more in a proteins and fibers. Very important, the role of fibers in this diet for these PCOS patient friends, and explain them. Now, if they reduce, but still you find that her cycles have not regularized, her picture is not improved, signs of hyperandrogenism has not come down, I want to start the treatment now, the metformin. Metformin is the drug of choice to improve the insulin resistance. Metformin works by decreasing the gluconeogenesis, lipogenesis, enhances the glucose uptake in the liver, skeletal muscle, adipose tissue, and ovaries. Friends, this is very, very, very important. Gluconeogenesis improvement and increase in the glucose uptake. It is known to prevent weight gain and appears to assist with the weight loss. But that is their another advantage. Patient should not feel that the metformin is going to give me weight loss, so I don't need to do anything. Explain her all these factors. Insulin sensitivity drugs, metformin, rosiglitazone, pioglitazone, D-chiro-inositol. What does the Cochrane says? According to Cochrane, metformin alone may be beneficial over the placebo for live birth, although the evidence quality was low. An improved clinical pregnancy and ovulation rate with metformin and clomiphene versus clomiphene alone suggests that combined therapy may be useful. Whether it translates into increased live birth. So what does Cochrane says is, when you are giving with the oral ovulation, give metformin. It will improve your ovulation rate. It will improve your clinical pregnancy rate. But whether it will get transmitted into live birth is not sure. But at the same time, also Cochrane says that if you are adding metformin along with gonadotropins, then definitely it not only increases your clinical pregnancy rate, but live birth rate also. So friends, today, what we are doing is, we are using metformin 1,500 to 2,000 per day. Of course, we start with 500 per day for a week, then make it 1,000, that is 500 BD per day for a week, and then you climb up, obviously, because of its GI side effect. Now the argument goes, the endocrinologists feel that we should not be giving sustained release. They believe in giving metformin thrice a day. This is what the opinion of few endocrinologists. I'm not aware of others, but I always will give a sustained release because it has a tremendous GI side effects. Sustained release, I've found, is little easily tolerated. The effect of metformin compared with the hypocaloric diet on C-reactive protein level and insulin resistance in obese and overweight. Very interesting study. So I thought I should be presenting to you. The aim of this study was to investigate the efficacy of metformin compared with hypocaloric diet on C-reactive protein levels and markers of insulin resistance in obese and overweight women. Although the weight reduction has equal efficacy with metformin in decreasing the CRP level, it was significantly more effective in improving the resistance in obese and overweight PCOS than in a lean PCOS. Effect of metformin on clinical, metabolic, and endocrine. This is very important. You have to imagine, am I improving the clinical pregnancy rate? What about the metabolic syndrome? Does metformin help? So this was a 2017, a very beautiful systemic meta-analysis, and their clinical outcome was on BMI, waist to hip ratio, systolic diastolic blood pressure, and others. And they have seen the endocrine outcome by studying the markers of them. Metformin showed significant improvement in clinical outcome, but not in a metabolic and endocrine outcome. However, heterogeneity between the study was found to be moderate and high, and that's why. But try to understand, don't even think that metformin you are giving, that patient should not think, now I will not get diabetes. Now my thyroid will get corrected if I have associated. Now I will be absolutely healthy and I will not have a cardiovascular problems. So they remain that metformin is going to work for everything. So friend, it is not so. Just explain to them that the lifestyle modification is the most important thing in it. If you see the international evidence-based guideline by ISHRE, ASRM, Monash University coming together, it is metformin alone or in combination effective for management of hormonal and clinical PCOS features and weight in adolescent and adults. What is they say is metformin in addition to lifestyle could be recommended. Always remember, in addition to lifestyle, can be recommended in all with the obesity of 20, where BMI is more than 25, for the treatment of weight, for the hormonal and metabolic outcome. Metformin may offer greater benefit in high metabolic risk group, including those of diabetic risk factor, impaired tolerance, and high-risk ethnic group. So definitely in a high-risk ethnic group, you start thinking of adding the metformin was another additional advantage. Now, before I go for a myoinositol, I need to tell you, majority of us have started continuing the metformin even during the pregnancy. The guidelines are changing and they ask us to continue the metformin till late third trimester. This is how we can avoid so many problems of first trimester, missed abortion, genetic problems, cardiovascular problems in the baby, neurological problems in the baby, but at the same time, gestational diabetes and other. So metformin is usually considered. What about the myoinositol? There is so much controversy. Friends, in my practice, I use myoinositol. I started using it and I'm very happy with its result. But at the same time, you should know that if your drug has higher doses, it may give a reverse effect than the positive. It will give a bad effect on the ovaries. Hyperandrogenism and the ovarian egg quality may be problematic. But at the same time, does Cochrane, does evidence allow us to use myoinositol? No, the evidence doesn't prove myoinositol to be used. So this is randomized controlled trial because it was 2021 I have taken. What they did is myoinositol with metformin and myoinositol alone they have used. Metformin plus myoinositol 4 grams per day and myoinositol alone. And they have asked the patient to try spontaneous conception. And the primary outcome was clinical pregnancy after 6 months, and secondary outcome was improvement in a metabolic, endocrine, ongoing pregnancy, abortion, and multiple pregnancy. And they studied both the things in the groups. After 6 months, clinical pregnancy rate was 42% when they used combined versus 45% when they used only myoinositol. Hence, myoinositol might be used alone as an insulin sensitizer to improve the metabolic, hormonal, and reproductive. This is what these people have said. That's why I showed you. This was not very old. This is 2021. And I definitely have a feeling with more studies coming in, myoinositol will be proved very good. Now, it will take another one lecture to know how myoinositol work, how it improves the glucose uptake and everything. Some other time we will talk about it. But what is important is there are studies which are coming up where myoinositol alone, though as of now, the drug of choice across the globe, in all the zones of the globe, metformin is the drug of choice. While there are few centers who are using myoinositol. What does the Cochrane says? Cochrane says, in light of available evidence of very low quality, we are uncertain whether it will improve the live birth rate or a clinical pregnancy rate in a PCOS undergoing IVF pretreatment. And they also say that it is uncertain that it will decrease the miscarriage rate or a multiple pregnancy rate. And they also no pool data, myoinositol versus placebo as there were with the metformin. So probably, I know Cochrane is not ready to accept. 2022 meta-analysis. Efficacy of myoinositol on anthropometric, metabolic, and endocrine. 17 randomized with more than 1,000 patients. 7 trials compared myoinositol with folic acid. 8 trials compared myoinositol with metformin, and 2 trials compared it with the oral contraceptive. And clinical significant improvement was not observed in anthropometric, metabolic, or endocrine outcome after myoinositol. So friends, they studied all those biomarkers and they felt that it was not improved. What about N-acetylcysteine? N-acetylcysteine can be effective adjuvant in PCOS related and unexplained female infertility. The effect could be more profound in women with the high BMI, insulin resistance, and oxidative stress. N-acetyl as an adjuvant therapy in a systemic review meta-analysis, they found no. According to them, they said that NAC was found less efficacious and safe than a metformin, and NAC showed statistically insignificant results, and that is why no one is using N-acetylcysteine today over metformin. Friends, I think I tried to explain you the insulin resistance. How important? Yes, 50 to 60% will have it. Whether we test it? Unfortunately, no. We go with the clinical. Then how it affects ovulation and endometrium. How do I treat? Metformin, the drug of choice. You want to give patient, especially which patients I give myoinositol as well. Now, the patient who I feel has an insulin resistance, I'm putting them for 6 months on a lifestyle modification. During that time, I explain them to keep the relation. Obviously, they have an irregular cycle. So I explain them twice a week or thrice a week they should keep, not Friday, Saturday, Sunday, but maybe Monday, Wednesday, and Saturdays. They should keep at least 2 or 3 times in a week relation. And these are the patients whom I put metformin and myoinositol combination also. And I have found that if they are very serious in their weight loss, if they take it very seriously, and if they are reducing with the rate of 3 to 4 kg in a month, by 3rd, 4th month, these patients will consume spontaneously. That is what my experience is. And that is what I tell the patient, counsel them so that they put in their efforts. Because if they are getting a spontaneous conception, nothing like it. So friends, insulin resistance, give an importance to it. I humbly appeal to those who are from India that on 1st August, the voting link opens. It remains for 10 days. Please go on Foxy membership website ensure your mobile number is correct. Get your Foxy membership number. It's a very simple. It is members@foxy.org. You will find that everything you can come. You can go on a Foxy website and go on the members data, and you will get that all. Get your Foxy membership number and ensure your mobile number is right. It's the game of numbers, dear friends. Keep me in your blessings, and thank you so much. Thank you.
Thank you so much, ma'am. It was a pleasure to hear you again. It was actually being a person from pharma background and have studied about medicines as well. It was kind of relating, and it was quite great. Looking forward for such great sessions in the near future again. This is Piyush signing off. Thank you so much, ma'am.
Thank you, Piyush.
Good night, ma'am.
Good night.